So imagine logging into your bank account and seeing this massive balance. Like you are officially rich.
Okay, I like where this is going.
Right. But then you go to buy just a simple cup of coffee and your debit card gets declined.
Oh, no.
You try to pay your rent declined. The money is literally sitting right there on the screen, but the bank has frozen your funds. You can't spend a single cent of it.
Yeah, it's a complete illusion of wealth. I mean, you have the assets on paper, but functionally, in the real world, you're entirely broke.
Exactly. And that exact maddening scenario is happening inside the bodies of millions of people right now. But instead of money, we are talking about hormones.
Which is incredibly frustrating for patients.
It really is. Because you go to the doctor feeling just utterly exhausted, you're dealing with severe brain fog, a completely non-existent sex drive, and maybe this unexplained weight gain.
Right, the classic symptoms.
Yeah. And the doctor runs a standard hormone panel, looks at the results, and says, great news. Your estrogen and testosterone levels are completely normal.
Which leaves you sitting there thinking, well, if I'm so normal, why do I feel like my body is falling apart?
Right. And that disconnect is exactly what we were decoding today. We've been digging through this massive stack of clinical reviews. We've got stuff from the British Menopause Society, insights from San Diego Sexual Medicine, and various endocrinology reports, all to solve this medical mystery.
It's a really crucial deep dive.
It is. Our mission today is to figure out why your lab results might say you are fine when your physiology is screaming otherwise. And the answer revolves around a protein that basically acts as your body's central bank vault. Specifically, we are looking at your baseline systemic levels of sex hormone-binding globulin, or SHBG.
Yeah, because if you are only looking at the hormones themselves, you're missing the entire infrastructure that dictates whether those hormones can actually do their jobs.
Right.
We really have to look at the transport and delivery system, because without understanding your baseline SHBG, interpreting a hormone panel is, well, it's essentially guesswork.
Okay, let's unpack this. I want to stick with that bank account analogy because a few of the clinical sources use a similar framework, and it just makes this incredibly clear.
It's a great analogy, yeah.
So your quote-unquote total hormone level on a blood test is the money sitting in bank vault, but your free hormone level, that is the liquid cash in your pocket.
Exactly.
And your tissues can only actually spend the liquid cash.
What's fascinating here is that to understand why that is, we have to look at the biology of the liver. Because that is where SHBG is actually born.
The liver, okay.
Yeah, hepatic production, meaning, production by your liver cells, is constantly churning out this specialized protein into your bloodstream. And SHBG basically has one biological imperative.
Which is?
It seeks out and binds to sex steroids circulating in your blood. So primarily estrogen, testosterone, and progestins.
But wait, why does the liver even do that? I mean, if our bodies need these hormones to function to give us energy, maintain muscle, fuel libido, why is the liver building vaults to lock them away?
Well, it's actually a brilliant evolutionary time release mechanism.
Oh, really?
Yeah. If your glands just dumped pure unbound testosterone or estrogen directly into your bloodstream, your body would just use it up almost instantly. Or your kidneys would literally just filter it right out of your blood and excrete it in your urine within minutes.
Oh, wow. So it's basically a preservation system.
Exactly. SHBG acts as a biological reservoir. By binding to the hormones, SHBG extends their half-life in your bloodstream.
Okay, that makes sense.
It keeps them circulating safely so they can be, distributed over time. But, and here is the critical physiological catch, while a hormone is bound to SHBG, it is biologically inactive.
It's locked in the vault.
Literally locked in the vault. The molecule actually becomes too large to cross the cell membrane, so it can't enter your tissues, it can't interact with your cellular receptors, and it can't trigger any biological effects.
Wow.
Only that small percentage of unbound or free hormones can actually be spent by your body.
So SHBG is the ultimate gatekeeper here. But how much of this protein is supposed to be circulating in our system on a daily basis? Like, if I look at a lab report, what does a normal baseline actually look like?
Well, establishing a normal baseline for systemic levels of SHBG is notoriously difficult because the reference ranges are just staggering.
How staggering are we talking?
For general adult women, a normal range is widely accepted as anywhere from 14 to 144 nanomoles per liter.
Wait, 14 to 144?
Yep.
That is a 10x difference. I mean, that's like saying a normal resting heart rate is anywhere between 40 and 400 beats per minute. How is that a helpful clinical metric?
You're touching on exactly why so many patients fall through the cracks of standard testing.
Yeah.
The range is massive because baseline shbg shifts drastically depending on your life stage and your metabolic state.
Okay, break that down for me.
So during the standard reproductive years, normally cycling women usually sit between 18 and 86.
Which averages around what, 40?
Yeah, averaging around 38 to 40. But when perimenopause begins, those numbers completely fracture.
Because the hormones are fluctuating.
Exactly. SHBG starts swinging wildly, anywhere between 20 and 75, as the body tries to adapt to fluctuating ovarian output.
Yeah.
And then postmenopause, assuming a woman isn't on any hormone replacement therapy, the baseline settles back into a wide range of 16 to 115.
Okay, I have to push back on the system a little bit because the math doesn't really seem to add up if we look at how the body normally regulates itself.
What do you mean?
Well, let's say my liver gets overzealous, right? It pumps my baseline SHBG all the way up to 130. It locks all my testosterone in the vault. I have no free testosterone left to spend.
Right.
Wouldn't my brain realize I'm broke and just signal my ovaries or adrenal glands to print more money? Like, why doesn't the body just naturally compensate by making more testosterone?
That is a highly logical assumption, but it reveals a really fascinating blind spot in our endocrine system.
Really? A blind spot?
Yeah. The feedback loop between your brain, specifically the HPA axis, and your reproductive organs, often measures the total circulating hormones, not necessarily the free hormones.
Wait, so the brain looks at the bank account, sees the massive total balance, and thinks everything is totally fine.
Yes. The hypothalamus senses there is plenty of total testosterone circulating, so it doesn't signal the factories to ramp up production.
Oh my gosh.
Meanwhile, your actual muscle tissue and your brain cells are literally starving for active testosterone because it's all locked up by SHBG.
That is wild, and it perfectly explains the central mystery of the quote-unquote normal lab test.
Exactly.
Like, two women could have the exact same total testosterone down to the decimal, but if woman A has a naturally low baseline of SHBG, she has plenty of liquid cash to spend on energy and libido.
Right.
But if woman B has a baseline sitting at the very top of that massive range, her body has locked all her hormones away. She is going to feel utterly depleted, even though her doctor says her total testosterone is perfect.
Which is exactly why looking at just total estrogen or total testosterone without measuring the SHBG baseline is a fundamentally incomplete picture. It's clinically inadequate.
Okay, so if the liver is controlling this entire economy, what actually causes the liver to change the interest rates? Like, what drives this hepatic upregulation, where the liver builds too many vaults, or downregulation, where it leaves all the cash on the table?
Well, let's start with hepatic upregulation. That's where the baseline SHBG is pushed abnormally high.
The hoarder.
Right, the hoarder. When this happens, your body gets starved of active hormones. You experience crushing fatigue, loss of muscle tone, brain fog, and a complete flatline of your sex drive, which clinicians actually categorize as hypoactive sexual desire disorder.
And what triggers the liver to hoard like that?
The liver is highly reactive to systemic stress and specific chemical signals. So hyperthyroidism, an overactive thyroid, accelerates metabolic processes, pushing the liver to oversynthesize SHBG.
Okay, so thyroid issues. What else?
Physical extremes, like anorexia or very low body weight, that triggers a starvation response where the body locks up sex hormones to essentially halt reproduction.
That makes sense from a survival standpoint.
It does. But arguably the most common culprits are medications.
Really?
Oh, yeah. Anti-seizure drugs, breast cancer treatments like tamoxifen, and certain synthetic estrogens found in birth control aggressively stimulate the liver to pump out SHBG.
Okay, so that is the overzealous vault scenario. But here's where it gets really interesting. What about the opposite scenario? What happens when hepatic downregulation occurs, the SHBG baseline crashes, and suddenly there are no vaults at all?
Right, the spender. When baseline SHBG drops too low, you have a flood of active, unbound hormones circulating in your system. And in women, the most noticeable and distressing impact of this is an excess of free testosterone.
Right. The sources outline a cluster of symptoms for this that basically mimic high testosterone. We're talking about rapid weight gain, particularly visceral fat around the organs, right?
Yeah.
Plus severe cystic acne, hair thinning on the scalp, but excessive hair growth on the face or body.
Yeah, those are the classic androgenic symptoms. But here is the critical underlying mechanism that every endocrinology report in our stack highlights. Low SHBG is a massive, blaring red flag for underlying metabolic issues.
Metabolic issues, specifically insulin resistance, right?
Yes, specifically insulin resistance, obesity, and PCOS.
How does insulin actually interact with this transport system?
It happens at a cellular level. When your diet or lifestyle leads to chronically elevated insulin, meaning your pancreas is just pumping out massive amounts of insulin to manage your blood sugar, that insulin travels straight to the liver.
Okay.
It physically binds to receptors on the hepatocytes, the liver cells, and it suppresses the transcription of the specific gene responsible for making shbg.
Wait, so the high insulin literally turns off the factory machinery that builds the vaults?
It completely shuts the factory down. The liver prioritizes the metabolic emergency of high insulin over the hormonal transport system. So consequently, shbg levels plummet, free testosterone runs wild in the bloodstream, and you develop the classic symptoms of polycystic ovary syndrome, or PCOS.
See, the timeline of this is what really caught my attention in the research because insulin resistance usually develops for years, sometimes decades, before your actual blood glucose levels get high enough to trigger a pre-diabetic A1C test at your doctor's office, right?
Exactly. The pancreas will often overproduce insulin for years just to keep your blood sugar looking quote-unquote normal on a basic lab panel.
So if insulin suppresses shbg, that means your shbg baseline would crash years before your doctor ever notices a blood sugar problem?
It does. We'll come back to the profound implications of that timeline later, but it just highlights how incredibly sensitive the liver is to our metabolic state.
Yeah, no kidding.
And if the liver is that sensitive to our metabolism, we really have to look at how it reacts when we actively introduce new hormones into the system, particularly when women enter perimenopause and menopause and look toward hormone replacement therapy, or HRT.
Because perimenopause is already this biological, chaotic event.
Oh, it's an endocrine storm.
Yeah.
Estradiol, which is your most potent natural estrogen, doesn't just elegantly decline as you age. During perimenopause, it spikes and crashes erratically.
And the liver is reacting to all of that.
Right. The liver is constantly monitoring this chaos, trying to maintain homeostasis. So as estrogen wildly spikes, the liver scrambles to synthesize more shbg to bind it up and protect the tissues. But before the liver can stabilize things, the estrogen crashes again.
Leaving the body with too much shbg and zero free hormones.
Exactly.
Which totally explains the unpredictable, debilitating symptom swings women experience. So a woman goes to her doctor, exhausted, and gets a prescription for HRT to smooth out the ride. But according to the clinical data, the actual physical route of delivery, like how she takes that hormone, fundamentally alters how her liver reacts.
Yes, this is one of the most vital clinical insights in the sources. The route of delivery dictates everything. Let's trace the biological path of taking oral estrogen, so swallowing a pill.
Okay, down the hatch.
Down the hatch. It goes into your stomach, gets absorbed through the small intestine, and enters the portal vein. The portal vein acts as a direct highway straight to the liver.
Okay.
This means the liver receives the entire concentrated dose of that estrogen pill all at once before it ever reaches the rest of your body. In pharmacology, this is known as the first pass effect.
So the liver basically gets hit with a massive, localized bomb of estrogen.
It is an overwhelming stimulus. The liver registers this massive influx, assumes there's a systemic estrogen overdose, and immediately fires up its defense mechanism. It churns out vast quantities of shbg to lock all that estrogen away.
But if a woman uses transdermal estrogen, meaning like a patch on her skin, a topical gel, a spray, or maybe a vaginal ring like yeast ring, the biological path is completely different.
Entirely different. Transdermal estrogen absorbs directly into the microscopic capillary beds in your skin or mucosal tissues.
Right.
It enters your systemic blood circulation immediately, delivering the hormones straight to your brain, your heart, and your tissues. It completely bypasses the digestive tract and that portal vein highway.
It skips the first pass effect.
Exactly. So by the time that transdermal estrogen eventually circulates back around to the liver, it is diluted. It looks like a normal physiological amount of hormone.
So the liver doesn't freak out.
Exactly. The liver doesn't panic. The transdermal route has a minimal, almost negligible effect on your baseline shbg.
See, this sets up a completely brutal medical paradox. I want to make sure I'm tracing this logic correctly.
Oh, for it.
So a woman is suffering from menopausal symptoms, right? Hot flashes, extreme fatigue, absolutely no libido. Her doctor prescribes an oral estrogen pill. She takes it for a month, comes back and says, my hot flashes are a little better, but my energy is still zero and my sex drive is completely dead.
A very, very common scenario.
Right. So the doctor thinks, well, the dose isn't high enough and increases her oral estrogen pill. But physiologically, by swallowing an even higher dose of estrogen, she is hitting the liver with an even bigger bomb.
Yep.
The liver panics more, pumps out even more shbg, which not only locks up the new estrogen, but also locks up whatever remaining trace amounts of natural testosterone she had left in her system. Her doctor is inadvertently making her fatigue and libido worse by increasing the pill.
It is an agonizing biological catch-22.
It's terrible.
The treatment literally creates a new dysfunction. But if we connect this to the bigger picture, following the mechanics of this transport system also reveals the solution.
Right.
This is precisely why a clinician can take a patient suffering on an oral pill, switch her to a transdermal catch keeping the exact same daily dosage of estrogen, and within weeks, her symptoms magically resolve.
Because by switching to the patch, she stops bombing the liver. The liver stops overproducing shbg, the vaults finally unlock, and her own natural free testosterone floods back into her system.
Exactly. The delivery method is often the difference between a patient feeling like they are losing their mind and feeling like they finally have their life back.
So knowing how delicate this balance is, how do doctors actually navigate this clinically? Like, how do they use this transport system to get patients back on track?
This brings us to the formal guidelines from organizations like the British Menopause Society and ICEC. They are incredibly stringent on this mechanism, particularly regarding the treatment of low libido with testosterone therapy.
Okay, what do they require?
Before a doctor is supposed to ever prescribe testosterone to a woman, a baseline blood test for both total testosterone and shbg is strictly required.
You can't just measure the money in the vault. You have to measure the vault itself.
Exactly. Because without both numbers, you cannot calculate what's called the free androgen index, or FAI. The FAI is the clinical formula used to determine your liquid cash.
How does the math work on that?
You take the total testosterone, multiply it by 100, and divide it by the shbg level. This gives you a percentage representing the bioavailable hormone.
And the guidelines state that index needs to sit within the female physiological threshold, which is typically between, 1.5% and 10%?
Right. And if you do not measure shbg, you cannot run that formula. You are flying blind, and you cannot safely or effectively dose testosterone therapy.
But let's say someone runs the formula and their shbg is completely out of range. So what does this all mean? How do we actually fix the protein level? Because, I can't just run to the pharmacy and ask for a bottle of shbg supplements.
No, you definitely cannot prescribe shbg. The entire clinical approach requires treating the environment of the liver. You have to treat the root cause that is driving the upregulation or downregulation.
Let's break down the two pathways. If a patient's shbg is abnormally low, meaning the vaults are demolished, free hormones are running wild, driving weight gain, severe acne, and PCOS symptoms.
The treatment there is primarily metabolic, because the root cause is high insulin suppressing the shbg gene.
So how do you fix it?
The clinical data shows that addressing insulin resistance is paramount. Losing just 5 to 10% of total body weight, shifting to a diet high in protein and fiber, and drastically reducing refined sugar intake lowers the pancreatic output of insulin.
And once the insulin drops, it stops binding to the liver cells, the liver turns the gene back on, and shbg production normalizes.
Yes, the body beautifully corrects itself once the metabolic interference is removed.
That's amazing. What about the other side?
Conversely, if a patient's shbg is too high, the overzealous vault scenario causing exhaustion and low libido, the fix requires investigating what is stressing the liver.
So step one would be checking their current medications, right? Like if they're on oral HRT or oral birth control, switching to a transdermal patch or gel bypasses the portal vein and allows the liver to calm down.
Exactly. And if medications aren't the culprit, clinicians must evaluate thyroid function for hyperthyroidism. And, we cannot ignore lifestyle stressors. Chronic, unrelenting stress keeps cortisol levels elevated, which creates a cascade of systemic inflammation that also pushes the liver to hoard hormones. You really have to look at the entire physiological system, not just an isolated number on a page.
Which brings us back to you, the listener, and your own lab work. If you go into your doctor's office complaining of bone-deep fatigue, brain fog, and zero libido, and they only order a total testosterone or total estrogen panel, they are literally only seeing half the story. You have to firmly advocate for yourself and request that shbg be included in the panel.
The clinical guidelines mandate it, the biological mechanics require it, and quite frankly, your daily well-being depends on understanding it.
Let's pull all of this together. We started with a baffling scenario, having normal hormone levels on paper, but feeling terrible in reality. We discovered that the baseline systemic level of sex hormone-binding globulin is basically the central bank of your endocrine system.
Right.
We traced how high baselines lock your hormones in a vault, starving your tissues, while low baselines demolish the vaults, letting hormones run rampant. And we looked at the massive physiological difference between swallowing a hormone pill versus absorbing it through the skin.
It just reveals how intimately our reproductive hormones, our liver function, and our metabolic health are intertwined. I
Mhm.
mean, you cannot manipulate one without triggering a response in the others.
Which leads perfectly to the timeline you hinted at earlier.
Right. And this raises an important question,
Yeah.
something that is a profound paradigm shift in how we view endocrinology.
Okay, lay it on us.
So, we've spent this entire deep dive analyzing SHBG as a gatekeeper for your sex hormones. But we firmly established the biological mechanism where elevated insulin physically suppresses the liver's production of SHBG.
And the key is that insulin spikes years, sometimes decades, before your actual blood sugar fails.
Precisely. So if SHBG crashes in the presence of insulin resistance and visceral fat long before glucose levels become abnormal, what if we stopped looking at SHBG merely as a frustrating variable in reproductive health?
And started using it as what, an early warning system?
Yes, as an early warning alarm system for our overall metabolic health. By tracking a patient's baseline SHBG, we could potentially catch the earliest whispers of insulin resistance, prediabetes, and metabolic syndrome years before a traditional A1C test ever raises a red flag.
Oh, wow. That turns a frustrating, obscure protein lab test into an actual crystal ball for your long-term metabolic health. It completely redefines the value of the blood draw.
It really does.
Well, thank you for joining us on this deep dive into the hidden infrastructure of your hormones. Keep digging into the science, keep advocating for the full picture at your doctor's office, and remember, just because the bank says your funds are there doesn't mean your body can actually spend them. We'll catch you next time.